this episode of the European Urology family of podcasts. This time, our focus is going to be on the latest issue of the European Urology Oncology journal.
That's right. So in case you weren't tuned in last month, we have had separate podcasts running for a couple of the journals, for European Urology, for European Urology Oncology. But due to popular feedback, they said, why don't you just do one a month, both of us together, like GUcast.
Get the family together.
Yeah, so we're going to be looking at our 4 journals really from time to time. And this month it's European Urology Oncology, which is the journal you've been working with.
That's right. And we're going to be joined by Editor-in-Chief Morgan Roupret and Associate Editor Riccardo Campi from Europe to discuss this issue. It's a bit of a landmark issue, Declan, because it's jam-packed. Lots of really great papers, new sections that we're going to highlight. So please do tune in because you'll get a lot of tips and tricks on what they're looking for in this journal.
And as ever, we won't be diving in great detail. We'll have some detail, but have a look in the show notes. We've got links to the whole index for European Urology Oncology in this every 2-month edition, plus links to the specific papers that the editors have picked out.
So we hope you enjoyed the July episode of the European Urology family of podcasts. So Declan, let's go over now to the European Urology Oncology team. We are joined in the studio today by Editor-in-Chief Morgan Roupret and Associate Editor Riccardo Campi. Welcome, gentlemen.
Welcome. Thank you.
Fantastic issue.
Thank you, Renu and Declan.
Wonderful. Great to have both of you join us today. It was a fantastic issue of the journal, jam-packed. It must have been tough to choose a couple of highlights, Morgan.
Yeah, it's true. But I'm happy to be there to highlight 2 papers of this issue, which is particularly important for us. As editor-in-chief, I have selected 1 paper in prostate cancer because it's not a clinical trial. It does not report new data, but I think I would like to highlight a thought-provoking position paper. The title is Expanding Risk-Adapted Early Detection of Prostate Cancer, a call to action for men at high risk. It's released in our new section of the journal, which is New Frontiers in Onco-Urology. And the question that it is going to raise is very important as we reached the point where prostate cancer screening should become truly personalized. And I think it is exactly why this paper deserves attention. For years, prostate cancer screening has been dominated by one debate: should we screen or should we not? And today, perhaps, we are asking the wrong question. The real question is, who should do it? And I think this is the main paradox today, because for years we have been doing genetics in patients with family history of prostate cancer. And the paper discusses hereditary mutation, of course. But what is particularly interesting is that in 1/3 of pathogenic germline variants that may be identified in prostate cancer, in men with prostate cancer, those are men without an obvious family history. That observation alone tells us that our current strategies probably miss a substantial number of patients who could benefit from earlier detection. I think it's one important message. There is another message which is particular that I have particularly appreciated, is that genetics is no longer relevant only for treatment. Genetics is very important, is a tool for prevention, screening, risk stratification. And so we are probably entering an era of precision prevention, which is totally another philosophy of what we have done before. And of course, it's a position paper, so many questions remain unanswered, but I think it opens a debate that is really interesting of the greater use of germline testing at a large scale.
Yeah, that's a great point, Morgan. We might just pause there quickly because this concept of genetic testing, I mean, we talked about that recently at our MDTs, now that we're seeing treatments kind of come earlier and earlier into the disease spectrum, especially things like PARP inhibitors. How important is it to be doing genetic testing in men at the initial diagnosis stage?
And this is a leap forward to saying to bring it forward to the risk-adapted, early detection phase. So I think that's why it's quite a provocative thought, and And I did really like this paper, this flow chart that they've put in to the paper, Morgan. The link is in the show notes to the whole paper, of course. With that at the top, it's got the germline screening right at that top room. So quite a provocative idea, but it's kind of, that's what we were talking about. It's the direction of travel. We only did genetic testing for like MC-RPC, and back in those days it was expensive, difficult to access specimens. Now it's like front end MHSPC with Talipro 3 and Amplitude. What about high risk localized men with a family history of bad prostate cancer? But this is quite provocative, I think, to take it further forward again, Morgan.
Yeah, the exciting idea is that one day we may combine genetics, PSA, MRI, clinical variables, and family history into a single individualized risk assessment. We are not quite there yet, but this paper argues convincingly that it is the direction in which the field is moving. And I think it's important to understand that, as you mentioned, Declan, the costs are decreasing. And that's very important because it was dedicated to few men only. And I think on a broader perspective, the general population will soon access to these genetic tests. And we as clinicians, when we go to conferences, congress, we exchange, I don't see that many people of the young generation truly interested into genetics. It is less fascinating than minimally invasive surgery, but the reality, the next big thing in medicine is there. So I think we should give full attention to that.
Fantastic. Now, before we move away from this paper, Morgan, we want to focus for a couple of minutes on the new section that you mentioned of the journal, the New Frontiers section. So tell us a little bit more about that, and what sort of papers are you looking for people to submit with the aim of getting it into this section?
It's important. It's under the umbrella of Alicia Morgans, who works in the USA East Coast, and she's very keen to attract papers that are dealing with the blurred lines of oncology. By that, I mean, we have been trained as specialists of organs. So Riccardo is there to represent kidney cancer. We have prostate cancer, bladder cancer, of course. But I think that the way we do medicine is changing. We are perfectly aware that oncology is not a disease of one organ, is a disease of a cell. So we share many things in common with all the colleagues that are dealing with cancer. And so in this section, we want to attract everything that it is not under the umbrella of prostate, kidney, and bladder cancer specifically, but quality of life, new way to treat cancer. But of course, not out of the blue, with a scientific rationale, and to highlight teams that are raising good questions in the field to try to move the field into a direction of, I would say, thinking a little bit out of the box in the field of cancer. So it appears very difficult to define, but we will put everything that is interesting and that we could not allocate into the kidney cancer section, prostate cancer section, and bladder cancer section. So I think it's a good way to attract new papers. And this is why each time there is a big conference, ESMO, ASCO, we spend a lot of time together with Alicia to look at the posters, to see who is presenting a new idea that it is a bit different from what we know already, and that could be interesting to reflect to our potential readership.
You know, Renu, the thing listening to that, it's always good to pick the editor-in-chief's brains on these things, because a lot of our audience, of course, are also potentially authors, and they're used to, trying to get their papers into these high impact factor journals, and it's difficult. Big journals like European Urology Oncology and all of our family. So I just find it fascinating to listen to the editor-in-chief.
To know what they're looking for.
Exactly.
Yeah.
So I think for people out there who, you're working on a project or whatever, don't just think, okay, is it bladder cancer, prostate cancer? This is a new section, and that means that the editor-in-chief and the triage editors like Riccardo and those, they're looking for something a bit different. Oh, that might fit there. And I think it's a shorter format as well. It's not like a 2,500 word.
Yeah, true, Declan, but we are quite flexible on that. As soon as it is good, we want to find a way and to accommodate to release it in the journal. So our purpose is to attract, and we try to be as flexible as we can.
Love it.
Fantastic. So those of you listening, we will put all the links to these papers that we're discussing on the podcast today in the show notes. So do check it out. See what kind of article this is that belongs in this new section, New Frontiers in Oncology, and make sure you give it a go.
All right, number 2.
Number 2, on to bladder cancer, Morgan.
Close to his heart.
Yes, there is another paper I'd like to highlight. It's an excellent review entitled Blood and Urine Circulating Tumor DNA in Urothelial Bladder Cancer. So we all know that liquid biopsy has become one of the most exciting areas in uro-oncology. Among all liquid biopsy approaches, circulating tumor DNA or ctDNA has probably generated the strongest clinical evidence, particularly in muscle-invasive bladder cancer. And this review in the journal provides an excellent overview of where the field currently stands. I have to say that at the personal level, the evidence is, for me, becoming increasingly convincing. In muscle-invasive disease, plasma ctDNA is emerging as one of the best biomarkers of minimal residual disease after radical cystectomy. We have several prospective studies, including InVigor and Abacus, which have demonstrated that postoperative ctDNA positively identifies patients at extremely high risk of recurrence, while ctDNA clearance during systemic therapy correlates with treatment response. But I think the most interesting question is the broader one. Will ctDNA become the single liquid biomarker for bladder cancer? Is it going to be the PSA of, I would say, bladder cancer? Personally, I doubt it, because history teaches us that oncology rarely converges on a single biomarker. Instead, it moves toward combination of complementary biomarkers. And I think ctDNA is the first step. It measures one important biological process: tumor-derived DNA released into the circulation. But to be honest, bladder cancer is biologically complex. Other analytes, including urinary DNA, methylation signature, RNA, proteomics, may each capture different aspects of the disease. So rather than competing, these biomarkers will probably complement one another. And this review actually reflects this evolution. So I think it discusses not only plasma ctDNA, but also urinary ctDNA, and highlights how assay methodology, tumor-informed versus tumor-naive approaches, and methylation profiling may all influence performance. This is an important reminder that we are not validating one biomarker. We are validating an entire ecosystem of liquid biopsies technologies.
Fantastic.
Wonderful and beautifully written too, and it's great to see that it has potential in both in multiple stages of the disease spectrum: localized, locally advanced, metastatic disease, post-cystectomy surveillance. So you can kind of see how this can become very utilized in the future.
The other thing, Renu, is you hear a lot about emerging biomarkers and this, that, the other, and for a lot of our audience, it is a bit bamboozling. ASCO GU, there's something about this, or often another refrain is, someone's presented new data and they're saying, and of course we need better biomarkers to help better select the patients. But it's now an important era, as Morgan was saying at the start, with trials like InVigor and those that are saying, yes, you can use these biomarkers to select, drugs like atezolizumab, etc., not just give the drug to everybody. And I think for a lot of our audience, it's a confusing area. I don't do much bladder cancer, but I try and keep on top of it. But I think this is a great review article. This is a really, really nice one. If you find this bamboozling, you do a lot of bladder cancer, your patients are asking you about it, dip into this paper, this what's called Blood and Urine Circulating DNA in Urothelial Bladder Cancer, state of the art. And you'll get a really good update. I found it really helpful, Morgan. And
what I really like about this paper is it's not just written in a purely scientific way. It really does show that clinical perspective and the relevance to practice in all these different stages. So fantastic paper. And I might put this question to Riccardo, who's been patiently sitting there. Riccardo, this is a review article. This is a systematic review. What would you say are the strengths of a good systematic review?
Thank you, Renu. Thank you, Declan, for first of all for the invitation, and to Morgan as well. So I think your question is key for our journal, because we truly want to receive the best systematic reviews in terms of methodology and in terms of study design. So now the statistical editor team of European Urology Oncology has recently published the guidelines on how to conduct and report systematic reviews and meta-analysis that I think are very important, together with all the guidance from statistical editors also beyond systematic reviews. I think all the authors who are interested in publishing in European Urology family of journals and European Urology Oncology in particular should read the guidelines carefully and including those for systematic reviews. I think a good systematic review starts with a good clinical question, so a good unmet clinical need, looking at the guidelines, research gaps, and trying to target a gap that is clinically meaningful for patients and researchers. And so we should start from the real beginning with a good question and a good methodology, planning all the steps of the review, a nice PICO, a protocol. That's very important, to have a protocol registered in advance in repositories like Prospero or similar, and then conduct the review carefully. But I would like to highlight that it's not only about doing the review, is interpreting the results and putting them into the context for the readership and for clinicians. A review can have a great value, in my opinion, for both clinicians and researchers, but it should be really contextualized. It's not a mere exercise of putting the literature and summarizing it.
Pearls of wisdom from Associate Editor Riccardo Campi. Morgan, would you agree? Do you get a lot of reviews? Is that something that's common that people want to do?
Not enough. I want more.
Okay.
It's because we just noticed that outside the strategy that we have as a team, editorial team, and the strategy also to disseminate the good information and to raise the impact factor, the systematic review are well, I would say, seated and used by the colleagues as soon as they have a presentation to make a lecture for a congress and conference. They go into quality review. So outside the review itself, it's also the group of authors that are coming together to deliver a message. And I think a good review as a methodology, as we express it in our guidelines, but it's also a message that you want to send. It's not just a review of data, but the way you frame the review, you are building the discussion is really interesting. And this is I would say the taste that we are looking for when we read the review outside the scientific judgment that we need to deliver.
And just about the process for potential authors out there. So you like to get a contact. You welcome a contact directly from someone to say, look, here's a proposed review. Here's some structure. Here's our proposed author list. I think that's important to do because sometimes there's already a review on that topic, like coming through or whatever. So that's still the case, Morgan. You welcome a direct approach.
It is perfectly true, and we are living in a world where we believe that machines are everywhere, and we want to the people feel that there is a human team at the editorial board, and we want the authors to have the ability to reach us out, reach Riccardo if there is any question, reach me, and so on. We are there. It is not going to be an interaction with an artificial intelligence interface. We have a group. We are working together, and we are very easy to reach. So anywhere, discuss with us before and try to find the best way to set all the tiny details that are going to make the product at the end, the article that we release, the best we can. It's not just machine sending in an editorial system, getting an answer. We want to put human relationship there and to be as empathic as we would be with our patient, with the authors.
Wonderful.
Love it. So that's what we love on this podcast. It was the same with Alberto last month. We got great feedback from that. Just hearing a little bit about how the senior editors think about that. It's really helpful because, It can be very frustrating, of course, having your papers rejected. Happens to all of us. Happens to you, even Morgan and Riccardo. But we really appreciate that side of the podcast as well.
Absolutely. Now, Declan, one of the special reasons we wanted to have Riccardo here today is that, EUO has had a lot of really strong renal cancer papers in recent issues. Yeah. So not just this past issue, but in the last few months. And Riccardo's special interest is kidney cancer, being associate editor, and he had to pick a couple out of maybe 6 or 8 papers, really great ones. We thought it was really important just to highlight the quality of these papers and the important work that's done out there. So you have managed to select a couple.
Yeah, thank you very much, Renu, for highlighting this. I think renal cancer is a disease that perhaps sometimes doesn't receive the attention of prostate cancer or urothelial cancer nowadays. There was also a recent white paper from the European Urology Association highlighting the gap between the research needs and the funding, for example, that renal cancer is receiving, and it will be presented later in 2026. But beyond this, I think European Urology Oncology is really a perfect journal for multidisciplinary articles on renal cancer, meaning the articles that deal with the aspects of the disease that are interesting for multidisciplinary tumor boards. And my idea is that almost all the disease pathway from diagnosis to treatment of metastatic disease are interesting for a broad multidisciplinary readership. And the idea of us as editors, and we discussed a lot with Morgan about the final decision on a paper, is really to reach such a multidisciplinary readership. So we really would like to have a lot of submissions also from medical oncologists, from papers on metastatic disease, especially papers dealing with the concept that are interesting for multidisciplinary tumor boards. So maybe not the specific aspects of treatment of metastatic disease from a medical oncology perspective, but those requiring input from multiple specialties, complex decisions to make, rare areas, etc. So it was indeed difficult to select 2 papers, but I would like to discuss with you 2 papers that I think highlight 3 concepts at the same time. An educational value, a scientific value, and a research value. So the first one is the COSMIC one-stop mass investigation clinic for renal biopsy. This was a prospective study, feasibility study, performed in Cambridge by the group of Grant Stewart. I think this was a very, very interesting paper for several reasons, because basically they enrolled patients in a feasibility study of US-guided biopsy with confocal microscopy to get the results of the biopsy within minutes, within the same day. Wow. Meaning that the whole process took really one day from the suspicion of renal cancer based on imaging to the diagnosis from an histological point of view. Even if the number of patients is not large, because it's 50 patients enrolled, but this is a prospective study, protocol-driven, very well performed by a group of experts. And actually the sensitivity and specificity were great, because we are dealing with 94% of sensitivity and 100% of specificity. Of course, this means restructuring your diagnostic pathway, having technology, meaning confocal microscopy, having a pathologist that is compliant and wishes to really be first in line in the clinic. There must be a good collaboration across specialties. But in the end of the day, patients were really got the diagnosis with a shorter time from biopsy to treatment decision and from suspicion to treatment decision. I think it's very important in nowadays complex oncology pathways to reduce the time from suspicion to diagnosis. It's very important for patients, but also for healthcare systems. So I think this paper really highlights what we can do for a procedure that is still controversial. If you think about the role of renal biopsy, we are discussing it for forever. And in the last 20 to 30 years, really the role of biopsy didn't change a lot. But perhaps with these technologies, we might improve on that and to get more information for the patient to decide on treatment, and not only a suspected renal mass at CT scan.
So interesting, Riccardo. And, you had us at confocal microscopy.
Yeah, we've had a lot to talk about.
We really have, and a lot of it to do with prostate cancer, actually. Yeah. So is this like histolog?
Yes, this is similar. Beyond the brand and the companies, I think the concept you highlighted is very important. We can use this technology for multiple reasons in urologic oncology, both in the OR and in the clinic, for diagnostic purposes and therapeutic purposes. So I think that's a key message. If one center want to improve on value with confocal microscopy, it can be used for several reasons. And in kidney cancer, I think this is important to highlight this concept of diagnostic pathway and reducing the time, improving the diagnosis with accuracy. Because, of course, you need to have a strong pathologist that is next to you in the clinic to analyze the sample. But I think this is another reasoning that technology really can allow us to speed up the process and improve also the uptake with patients. Patients sometimes are worried about the time from biopsy to the result, and then all the delay in treatment decisions.
Yeah.
This can be really solved.
If I may jump in.
Yes, Morgan.
I think it's important. He has a strong point, Riccardo. For many years, we have been saying, okay, look, kidney cancer, for example, is not an emergency. It's a slow-growing phenomenon. But we have to understand that as physicians, someday we could also become a patient. And from the perspective of the patient, it's always a lot of anxiety to wait for the outcome of the biopsy and so on. So anything, any technology that is likely to reduce this timeline and this time gap between the start of the process of the diagnosis and the ultimate outcome is a good process, because they live with a sword of Damocles above their head, and it's honestly a difficult period for them. So I think that outside the prognosis of the cancer itself, we all agree on the fact that we have time in the field of kidney cancer. It depends according to the situation, but in the majority of the cases, it's also to be with the patient and to understand that. Back in time, we had frozen section analysis in the OR, and we had some information that we are missing now. And this new technology is bringing a new 2.0 frozen section analysis in the OR, bringing really accurate information that we can deliver spontaneously or very rapidly to the patient. And I think it's an important process also to decrease the anxiety.
A few comments I'd make about
and Morgan,
yeah, sorry, Riccardo.
No, sorry. I think another point of having the diagnosis on the first day for localized renal masses, for example, is that you can really discuss in the MDT the biopsy result, and having all the information you have to select, for example, surgery versus surveillance versus ablative therapies, because we all know that the problem of ablative therapies and even SBRT nowadays that is increasingly being used is to have biopsy information beforehand. So I think this paper challenges the concept that we should not treat anymore renal masses, or maybe in the future, I think, renal masses without histologic information. This is really something that in kidney cancer we should go toward as learning from the other tumors. Basically, in kidney cancer, we are treating many patients without information on the biology of the disease, on the histology. So I think this is the right way forward.
Wonderful. And sure enough, speaking about decreasing the length of time. So in this paper, the time from time of consultation to the time of treatment decision making was 25 days compared to 55 That's almost 2 months that a traditional patient would have to wait. So it's wonderful to be able to at least streamline that a little bit, and surely this will help to ease pressures on hospital waiting lists and clinics and multidisciplinary meetings. Patients being presented multiple times, like you said, because you just have the lack of information. So it's a great way to streamline all of this.
And we've done a couple of podcasts on GUcast in the past year on confocal microscopy, mostly about prostate cancer, and focusing on the histolog machine, which is another confocal laser microscope. This is the Vivascope, I think, in this trial. But it clearly shows you there's interest. And if we could give a plug for one of our rival journals, our friends at the BJUI just this month have published a whole themed edition, an extra edition on confocal laser microscopy, and there's a Delphi consensus process, and we attended that meeting in Belgium a few months ago and did a podcast from it. So yeah, please go and look for this paper. And as you point out, it's a prospective, protocol-driven 50-odd patients. So the key word is prospective. That's why Riccardo and Morgan get attracted to this. It might only be 50-odd patients, but it's the fact that they set up a protocol, it was very correctly designed, ethics approved, and prospectively evaluated. So that's why it's in EUO. So yeah, great paper.
And great name, Cosmic.
Cosmic.
I love that.
And the other one.
Fantastic, Rick. And speaking of multidisciplinary care, the next paper you've chosen is about shared decision-making.
Yeah, this is, I think, very important to be highlighted and to be explained because these may sound a little bit out of the scope, but I think this is a very important study. The shared decision-making RCC study is really a prospective pre-test, post-test study that was performed in several hospitals in the Netherlands. And this is, again, a prospective study, but the beauty of the study is that shared decision-making was the intervention. So I think, as far as I remember, this is the first study testing implementation of shared decision-making in a prospective fashion, addressing both the clinicians and patient side in kidney cancer. But I think this is also important for other cancers as well, meaning that we can really test the concept of shared decision-making in a clinical trial setting, because we all discuss shared decision-making as is something that is very, I would say, personal or very heterogeneous, because we accept heterogeneity of how we do shared decision-making in practice. However, there are tools to measure it. There are implementation training tools that we can do as clinicians as well. And I think the results of the study that are basically that post-test, the shared decision-making perception of patients improved after these pre-test intervention are very important for the GU community, because it shows that we can really improve our training skills as clinicians in how we consult patients. It's not just a matter of whether we are born with skills, communication skills, or empathy, as Morgan discussed before. We can train these abilities as professionals, and we can really make the impact, an impact on patients' decisions. However, I think the results of the study are also interesting in the negative way. So the authors found that patient-reported shared decision-making did not change a lot, meaning that we are not perhaps capturing everything of the patient experience with this test, with these tools. And I think it highlights really the complexity of the decisions that we face in the GU oncology area, where we actually need to get the patient feedback and preference. But these are really important areas. How the patient decides, we actually don't know. And whether we are good enough to elicit the patient's view, actually, we don't know. So I think this study is very provocative and thought-provoking in this way. And but this is evidence. This is really evidence from a prospective study, very well conducted, very serious authors. And I was really happy to receive it and to manage it.
What a great concept, right? I mean, and we battle with this a lot, I think, and especially in kidney cancer. I think empowering patients to kind of participate in the decision-making process can be really tough. I mean, we see it now in the era of adjuvant treatment for locally advanced renal cancer. I mean, you want to ask the patient what they would like to do, but a lot of patients turn around and say, whatever you recommend.
What do you think, doctor? What's the best?
Yeah. And so I do think there is some skill that can be learnt in involving a patient actively in that decision-making process.
And Renu, you touched, I think, the point that I was thinking during my conversation. Adjuvant therapy is one of the examples. Also, the field of localized renal cancer in terms of choosing between ablation or SBRT or surgery or even active surveillance is another point. Yeah. I think we don't have to fall into the trap of giving the patient the full responsibility of the decision. We need to guide the patient, but we need to guide in a good way and in a professional way, I would say. And this study actually included a specific training for healthcare professionals with video recordings of the visits. So it was really a very complex design and very difficult to perform. I think the authors should be congratulated for having really conducted the study, because it's very unusual and very difficult to record clinical visits with an arbiter looking at how clinicians are managing patients and counseling patients. So I think there are a lot of learning points, including the fact that the time and the time for each visit and the number of visits actually increased in the study. So we know that if we do shared decision-making correctly, the time that we spend with patients actually increases. This is like an investment for the good decision. So I think the cost of the decision in terms of cost of time that we spend with patients needs also to be recalibrated on the quality of the decision that we take. So it's really I would say a value-based framework around all the decisions.
Oh, what a great idea. What a novel idea.
2 great papers, 2 great kidney papers, a great prostate paper, a great bladder paper, and lots more in the journal. We'll put the full list in the show notes as well. It really is a jam-packed
I think, Morgan, what I'm really impressed by, with your selection of papers today is we've kind of seen the breadth of the type of papers that the journal likes to showcase, which is great.
Yeah. For us, it's a landmark issue because it represents what we try to present as the new face of the journal. We have only 6 issues per year, so when we put together all the paper, it's not just to bring and merge. We try to have an editorial line that reflects to convince everybody that, as we mentioned earlier on, cancer is a very complex situation. So we want to treat all aspects of cancer. It's not only surgery or prescribe a pill or give a good trial. It's always the way we deal with the patient and the way we treat cancer in a modern fashion. So we try to reflect everything that comes to the journal and trying to find a red line that we can read from an issue to another. So I think it's very, very important for us to try to build a momentum and a path in the way we deal with cancer today.
Morgan's having a few connection issues, but I feel like he's pausing for effect.
Yes. And despite that, the Zoom was just breaking a little bit, but really good.
If you watch on video, it's great.
Great wrap-up.
Well, Morgan, Riccardo, thank you so much for joining us on this episode of the European Urology Podcast. You guys do an amazing job. Your contributions to the field of urologic oncology, really brilliant. And, can't wait for more people to submit their papers and their ideas.
There you go. Thank you so much.
You are doing a great
Thank
job
you very
too.
much.
Thank you, guys.
And also
Thank
a
you.
shout
Thank
out
you so
to
much.
the
It's always a
GUCast that
pleasure.
Morgan is giving us by wearing the cap.
Yes, you know what? He's got a GUCast cap on back in Paris. So thanks for the free plug. We must send Riccardo something for the
We
next
will,
edition.
for sure.
Great. Thank you,
Thank you
gents.
very
Okay,
much.
see you soon, guys.
Thank you very
Have a
much.
great
Bye.
summer. Bye-bye.
Thank you. Bye-bye.
Well, there you go, Declan. That was fun.
It was good. Yeah. We could have gone on for longer because that issue is jam-packed, isn't it? But
And we also wanted to highlight those important renal cancer papers as well. So Riccardo did a great job highlighting those papers. And as ever, we will have all these papers in the show notes. The links will be there so you can check them out, read at your leisure.
we'll be back next month with the European Urology Family Podcast for August. So please stay tuned and subscribe to European Urology Podcast wherever you get yours. Thank you.